Hello friends, after your fantastic response for a couple of lectures, I am presenting third lecture in the series of lectures on fetal echocardiography. I am going to cover 4 to 5 interesting topics and you will find it interesting. That's all I hope. Kindly give us your feedback so we can try to improve our presentation and cater your needs. So, first topic that we are going to discuss today is etiology of fallow. It is one of the most common congenital cyanotic heart disease. Remember what the cyanotic heart disease. It's common as cyanotic heart disease. Most of us know what are the components of tetralogy of Fallot. Tetralogy means 4 things. It was described by Fallot and consists of malaligned subaortic VSD. VSD most common is perimembranous, but we can say outlet, inlet, muscular, or any combination of above, or we can have multiple VSDs in this setting. It is associated with severe pulmonary stenosis. It can be valvar, supravalvar, subvalvar, or all three places. Right ventricular hypertrophy and overriding of aorta. So this is an anatomical depiction of tetralogy of Fallot. On the left side, what we see is a normal heart. As against on right side, what we see is a heart with the tetralogy of Fallot. So this is a pulmonary stenosis. This is malaligned subaortic VSD. What does malalignment means? In normal VSD, the VSD is like this. So aorta is totally committed to LV. In malalignment, aorta is committed to RV and LV both. You will understand on echo images how malalignment looks. RV hypertrophy. So these are the 4 components of TOF. Pulmonary stenosis, RV hypertrophy, VSD, malaligned, subaortic, and overriding of aorta. It is, as it is a commonest lesion, so we'll see a lot of association. Association may include right aortic arch, pulmonary atresia, absent pulmonary valve, non-confirmed pulmonary arteries, arterial duct on right side, vascular rings, multiple VSD, muscular outlet, inlet, AVSD with trisomy 21. We have seen a case like this in initial presentation. Presence of aortic stenosis and coarctation is extremely rare in right-sided obstructive lesions, so it's very, very rare. So if you find anything, it's worth sharing. So what are the fetal echo findings that we are going to see in this? Important thing in 4-chamber view is generally normal if it is a perimembranous outlet VSD. LVOT view shows malaligned subaortic VSD, aorta arising from both the ventricles. RVOT view shows narrow outlet, narrow pulmonary valve, pulmonary stenosis. Short axis view, VSD and small RVOT. Three vessel view shows is very difficult to. I'm going to stress on this again and again that main pulmonary artery arising from RV is sometimes difficult to see. So we have to search for third vessel. Okay, aortic arch, ductal arch, and corticocanal strip. So we are going to cover these important topics. Once we go step by step, we will understand the lesions. So understanding malaligned VSD. So looking at this image, this is left ventricle, right ventricle. This is the VSD. VSD is this. If this is the plane of VSD, so aorta is committed to both the ventricle. So this is malaligned VSD. Aorta committed both the ventricles, as against routine VSD committed to only LV. This is a pictorial depiction for your understanding. A 4-chamber view that is essentially normal. We cannot comment anything abnormality. If we just look at 4-chamber view, we can see normal upsetting of AV walls, apical trabeculation, cranially placed mitral valve, legs apex. Now again showing malaligned subaortic VSD, LV, RV, and VSD aorta. So LV and RV both are feeding the aorta. Okay, aorta is arising from both the ventricles. This is crossing of inlet. LV giving rise to aorta and RV giving rise to MP. You can appreciate the crossing. The size of MP is small. Just notice that the size of MPA is small. Now, just to mention my point, how the size of MPA can be small and difficult to show. This is the aorta and this is the MPA bifurcation. MPA, RPA, and left pulmonary artery. So as compared to routine heart, these are very small vessels. It is difficult to demonstrate these vessels. So it's important to look for them specifically and search them. Again, for just for a point, ascending aorta and this is descending aorta. This is on right side, suggestive of right aortic arch. So in this image, it's difficult to apply. We can just see the LPA, but RPA, this is RPA. LPA is not seen, but LP can be seen with the flow. So when we can't see the vessels, it's important that we put the Doppler image, color Doppler, and demonstrate the flow. This is the right arch. This is LPA, RPA. And this is a very small thing that you see is a main pulmonary artery. This is big thing is aorta. This is the spine. This is RVOT. It's very small. As the duct is open, the pressure across pulmonary wall is equal. So we don't see the gradient. We just demonstrate the anatomical narrowing. Okay, that's important. There is no pressure gradient in fetus. Pressure gradient is seen after duct is closed. PA pressure comes down after delivery. Okay, in utero we don't see pressure gradient. We just see narrowing of pulmonary MPA and RVOT. Three vessel view. This is SVC. This is aorta. MPA is not seen. So duct is not difficult to appreciate, and this is the right arch. Okay. Now this is aortic arch. Aortic arch giving this is the aortic arch. Okay, but the aortic arch is not going giving rise to any duct or there is no flow reversal demonstrated. It is important. If flow reversal is seen, you will see in some cases, then it's a different thing. The management changes significantly. Maybe we will need neonatal interventions. Again, this is the MPA bifurcation. This is the RPA, right pulmonary artery, left pulmonary artery. Otherwise, it's difficult to show this on the 2D image. It's better seen on color image. Okay, this is the descending aorta. Important to show vessels with color image if they are not seen with the on plain 2D image. That's what I want to say. Again, showing small pulmonary artery with color which are otherwise difficult to see on the 2D images. Just see it again and again, you will appreciate what I am going to say. Importance of color Doppler in showing things which are not apparent easily. Okay. So this is small MPA as compared to aorta going here as the RPA, and we can see LPA here, the distal part of LPA. Okay. We have already demonstrated bifurcation in initial images. Just making a point for a small branch piece seen in tetralogy of Fallot, which are difficult to demonstrate. So this is a sweep. So we can see the large aorta arising from the both ventricles and very small PA arising from RV. Otherwise, fundic bubble and LV apex is on same side. So rest of cytosolitis levocardia. Fundic bubble and LV apex is on same side. Cardiac apex is normal. Okay, so understand AVVA segment analysis, which is concordant in this case. Coming to now second image, again Malal and VSD. This is the interventricular septum and this is the aorta. This is the plane of aortic opening. So it is combined both RV and LV. Okay, so this is Malal and VSD. Whenever you see Malal and VSDs, think of one of the vessel is stenotic. It can be either. Again, a Malal and VSD. It shows very clearly how the Malal alignment looks. A presence of Malal and VSD, it is easy to demonstrate than just a perimembranous VSD because the anatomical defect is generally large. And once you demonstrate Malalan VSD, it generally refers to vast number of conotruncal anomalies, or TJ VSDPS, or CCTJ VSDPS, or uh, toxic being. All this has got a Malalan VSDs. So it can be seen with any of the above, or even a Trachus patricia can sometimes have a Malalan VSDs. A small MPA and difficult to demo. This is the aorta and giving rise to aortic arch. This is the left aortic arch and small MPA going as a RPA. LP will demonstrate. Okay, there is no flow reversal, so there is no pulmonary atresia. Okay, this is RVOT. Again, three vessel view, only two vessel, SVC and aortic arch. MP is difficult to demonstrate otherwise. So this is dilated aorta and small MPA for continuing as a RPA. This is the LP will be here. Just look at the senior loops again and again, again and again. So we'll appreciate the image and try to understand. Understand, once we know the anatomy, we can look for it. Again, making same point here, we can clearly see the LPA, RPA bifurcation, small vessels, forward flow, and the ductal flow here. Ductal flow is also seen, aorta and descending aorta. This is ascending aorta, descending aorta. This is RVOT. So all things relevant to outlets in the top are clearly seen in this image. Forward flow in MPA, no flow reversal in ductus. Little change in angle as compared to the last image, but it's how we demonstrate the small branch PAs in a tetralogy of Fallot, which are otherwise difficult to show. If you don't demonstrate them, then sometimes it is labeled as truncus or all sorts of things are labeled. So take a little extra effort to demonstrate them. Again, Malalan VSD. So another case, perimembranous. Both AV walls, this is left, right, cardiac apex, spine. Note the orientation of heart into the chest. Okay, again subaortic VSD, this is the IVS, interventricular septum. This is the aortic arch. This is the spine. Okay, this looks like a right aortic arch, but sometimes in obese patient or prone, it's difficult to show things very clearly. And this is the small branch PA. Aortic arch, no flow reversal, very well demonstrated aortic arch. And a small RVOT. Just look at the small RVOT. This is the RVOT. This is the aortic arch, RVOT. This is the branch PAs. Okay. In this case, has got right aortic arch. Top close to 25% has got the right aortic arch, and top pit is a 50% chances. So this is the crossing of outlet. LV giving rise to aorta, and RV giving rise to PA. The perimembranous VSD should aorta is committed to both things, but important to show the crossing. Crossing was demonstrated suggest a normally related gate arteries or VA concordance. So after going through the top, you will see a variety of top with absent pulmonary wall. This is a very rare variant where there is a wall tissue is absent, but we can only, but the annular narrowing is there. Okay, so it leads to both stenosis and regurgitation. And stenosis is from the small annulus and regurgitation is from the absent pulmonary wall. Duct is absent by the rule. Now the important thing is that normally 55% cardiac output goes to RVOT. Now this is not possible as duct is absent, so it leads to regurgitation. Diagnostic feature in this case is severely dilated branch pulmonary arteries. We'll show how they look. Okay. In neutral presentation, severe PR can lead to occasionally drops and fetal demise. After birth, dilated MPN branches can lead to airway compression. Again, I mentioned dilated MPN branches is a diagnostic feature. They can have a syndromic association with discharge. Very occasionally, they may not present early, they may present late, but late presentation is not so common. Then common presentation is early. So looking at the 4-chamber view, it looks, or maybe 5-chamber view, aorta arising and VSD committed to both the things. Cardiomegaly may be there if baby has developed hydrops. So this is the VSD, aorta, RV, LV, malal sub aortic perimembranous VSD. So you can appreciate the VSD better here. Okay, this is the VSD, aorta, left ventricle, right ventricle. So 4-chamber heart, RVOT. Now coming to the next image. Appreciate the aortic arch, which is a good size aorta. It's important to understand the size of aorta because we'll have to compare this with the size of PA branches. We have seen extremely small MPN branches in the top. Now we will see the paradox. Now look at this image. This is the dilated PA, RPA and LPA. They are as big as aorta. We can see there is a forward flow and backward flow. The flow reversal from red flow reversal of PR and forward flow is showing a turbulence. So PSPR. Okay. So this is a diagnostic feature of top absent pulmonary valve. Again, it's a forward flow, backward flow, dilated PN branches, and this is aorta. So this is a top absent pulmonary valve. I have demonstrated this with a cardiac probe. Forward gradient, backward gradient. This is the forward gradient, blue, and backward flow is red, PSPR. Okay, with a cardiac C5, S5 probe, not C5 probe. With another, now this is the annular stenosis and pulmonary wall, dilated pre-and branches. They are bigger than aorta. See, this is the aortic annulus, ascending aorta. This and compare them with the size of RP and LP. RP, LP are bigger than the aortic ascending aorta. A very unique feature of this condition. Again, RPA and LPA branch PAs and ascending aorta. Compare the size. They are bigger than the aorta. Stenosis at pulmonary wall level. Okay, we cannot appreciate any wall tissue here. No wall tissue. Now this is a PR jet. This is forward aorta. In 3-vessel view, as the duct is not there, it is not completely formed. We can just see MPA, RVOT, duct, MPA, RVOT, this part, aorta, no duct. SVC will be here. So 3-vessel view is not complete. Only 2 vessels are there. Duct is absent in this. A sweep, just to try to go through it again and again. I'll run it for 3-4 times so you understand this. Cardiac apex and funding bubble, AV concordance, VA concordance, perimenus, VSD, all things are quite well seen. This is the continuous wave Doppler from a cardiac probe. This is stenosis. The rent is almost 30-35 mmHg. This is a regurgitation jet. PSPR jet. This is a pulmonary stenosis. This is pulmonary regurgitation. Coming to next topic, top pulmonary atresia. It's a rare variant, not so rare, but it's an uncommon variety. It's one of the most severe form of top. Okay, the pulmonary atresia is there means RV is not in continuity with branch pulmonary arteries or MPA. Atresia can be at valve, it can be at muscle, it can be at MPA. Now there are many varieties. The branch, the right and left PA may be confluent They may not be confluent. They come from duct. They may arise from any branch. It can from DT, descending aorta. It can be from any neck vessels, abdominal aorta. All permutation combination are possible. Right arch is very common in this subject. The important feature is that duct arises from undersurface. Normally, duct arises here after left subclavian, here somewhere. So we will see duct like this. The duct is in continuity with the MPA. But here the duct arises from the undersurface against first or second branch. So it's a vertical duct. So if this is the arch, you see duct like this. Now sweep, you will just see a aorta arising from and AV concordance to ventricles. There is a echogenic focus seen in one of the ventricles in LV. Just to mention, make a point, the arch is right, fundic bubble and LV is cardiac apex is on the same side. Again, trying to show that the PA is not seen sweep in another angle. The fourth chamber view looks okay, and there is a perimembranous VSD in this position. And this is important. What we are seeing now, this is the aortic arch, and this is the duct giving rise, the flow reversaling duct, the branch PA. This is the right aortic. This is the spine. Okay, this is the spine. This is the right arch. Okay, and if you can see, this is the SVC flow. This is the right side. So right aortic arch. Dilated MPA, neck vessels, and this is the one of the branch pulmonary arising very close to aorta. Again, spine, arch, and LPA. Once okay, left pulmonary artery. Initially we saw was right. This is the left pulmonary artery. Okay, just see from under surface of the aortic arch. Another patient. I got only one image, but it's a very descriptive image. There is a VSD here. There is no forward flow in MPA. This is the branch PAs, and this is a ascending aorta, descending aorta, and this is the red flow that you see the top. So everything that we see in a top is seen in one this image. Top pulmonary atresia. Okay. This is very informative. Just look at this image again and again. All things seen with top pulmonary atresia are seen. Branch pH small, flow reversal in duct. This is red flow reversal. Always look for this flow reversal. You have to be very vigilant to understand this. Coming to another important lesion that we commonly see is tricuspid atresia. Atresia of right AV valve or tricuspid valve. It's with a hypoplastic RV. A combination of many. It can be normally rated. It can be transposition. It can be double outlet. It can come with AVSD. A normally rated gradius can come with pulmonary stenosis, pulmonary atresia, and increased pulmonary blood flow. Same with transposition, but it is more commonly seen with aortic arch obstruction, wall obstruction, and coarctation. We will see a case like this. Occasionally, you can see a total anomalous pulmonary venous connections. And left SPC is quite common with tricuspid atresia. These are the varieties. This is the pulmonary atresia, small RV. See, if pulmonary atresia is there, RV is small. Stenosis is there, RV is little big. And increased flow, the RV is very big. Okay. Now this is pulmonary atresia, RV is big, aorta is transposition physiology. Now PS is there, and this is PH. RV becomes smaller. There is a aortic stenosis. There may be coarctation. Okay, so this is the transposition comes with other obstructive lesion. Now this is the sweep of tricuspid atresia. Now we see dominant left ventricle, only one AV wall. There is a right ventricle which is small. There is no feeder from AV wall to right ventricle. Aorta arises from left ventricle and PA arises from right ventricle. This is aorta from LV, PA from RV. We will see all the analysis lesions are seen left aortic arch and they all form confluence here, duct here. Okay, so whatever we want to see in the case of a tractus patricia, normally get artery is seen here. So AV valve, this is the ASD, VSD, RV, LV, all things. This is the VSD. Obligatory left to right flow. I won't say shunt, it's a flow, obligatory flow. Otherwise, there won't be any PA circulation. Now another case. Now this is difficult imaging, but see, this is the left ventricle, very small right ventricle. This small. Okay, this is LA. This is RA. I just drawn the images for you to understand what is the orientation of the chambers. It's a very small VSD. A short axis view, big LV and very small RV. Small RV, big LV. Okay. Same a short axis view just to show how small RV is in this case. Now coming to, there was no forward flow and there's a flow reversal in duct. So this is the aortic arch and the red flow in the duct is just a flow reversal. Once we demonstrate flow reversal in duct, we are dealing with pulmonary atresia. It's important. We will demonstrate the flow reversal in aortic arch also when we discuss HLHS, but now we are dealing with pulmonary atresia, flow reversal in duct. Another image showing flow reversal in duct. This is the aortic arch, more of a sagittal image. Okay, this is a normal flow and flow reversal. And this is the LPA, one of the branch PAs arising from duct. The flow reversal is red. Okay. The aortic arch. Long axis view, LA, LV, aorta. This is small RV. Okay. Now in this case, it's very virtually impossible to demonstrate the RVOT and crossing outlet because it's generally absent. You can just see a very small PA here, thread like PA, very small here. Otherwise, we can just see one areola atretic small RV and a tiny MPA. Sweep in another angle. No doubt there is small MPA, but difficult to show whether they. Now coming to tractus patricia with transposition of great arteries. Important thing is that this is aorta and this is MPA. They are parallel. Aorta is anterior. These are the neck vessels. Okay. So aorta is far away from mitral valve. Aorta mitral discontinuity. These are features of not a normal heart. It's a TG or anything else but a normal heart. Now demonstrating, this is the LV-RV. These are the parallel great vessel. This is the PA and this is the aorta. This is the funding bubble. I'll try to demonstrate it more detail. Now we can clearly see this is the left ventricle, VSD, small RVO, small MPA, and big aorta. Aorta is from this outlet RV, chamber or RV, and main pulmonary artery is from the LV. So suggestive of VA discordance or transposition. Again, same point. MPA from LV, aorta from outlet chamber RV. This is the VSD. This is LA, mitral valve. Now sweep, we may or may not see, but important thing in the sweep is that we just see one great vessel, very clearly one ventricle and one areola. Okay, so we are not dealing with normal heart. Segmental analysis is at least this much we can understand. So see the sweep again and again. Try to see these images in a dark room, so we'll understand. If you put it in the light on, then uh, we won't be able to appreciate the black and white images. Now, tricuspid tissue with pulmonary tissue. Now, this is a strip, another case. There is only one AV wall, one great arteries. Okay, funding bubble and apex is on same side. We don't see the right side, we just see the left side. Okay, so we are dealing with a case of tricuspid. We also see the drainage of pulmonary veins. I'm not given importance of pulmonary venous drainage in this case because they were normal. But when we deal with TA, PVC or Sanderson anomaly, I will demonstrate them. There no AV wall regurgitation. Okay, and this is the flow reversal. This is aortic arch, and this blue flow that you see is the flow reversal. So it's a tricuspid tissue, pulmonary tissue. And again, should go to the. This is the. Again, show you the. There is no RVOT. There is no vessel coming. There is no RV per se, or very rudimentary. That's what I want to say in this. Coming to this now again, this is the arch and this is the flow reversal. Okay, this is a blue flow, this is a red flow, and ideally there should be both should have blue flow going away from the transducer, but flow reversal is opposing colors. Again, demonstration of flow reversal. We can clearly see a vertical duct. Normally duct should be like this line, but this is a coming from here, from under surface of arch. This is a little difficult case to understand. This is a tricuspid trachea, TGA, AV wall regurgitation with obstructive left-sided lesions, obstructive aortic lesions. Okay, there is no crossing. Both arteries are arising from close to outlet. So this is the AV wall, single atrium. Now there is no inlet, primum septum. There is no there is inlet VSD, so we can argue that is AVSD. So just I made a point initially. AVSD is associated with tricuspid trachea. Why I'm sure. Now this is one vessel seen in three vessels. Other vessel is not seen. One of the vein SVC is seen. So this is one of the vessel. Whether it's aorta or PA, we'll see subsequently. Now sub-11 arteries arising from the descending aorta. Okay, just in this case. AV wall regurgitation. Once we come across AV wall regurgitation that was of this magnitude, we generally think whether this is AVSD. Now, demonstration of AV wall morphology is sometimes difficult due to fetal lag, as it was in this case. Again, demonstration of AV wall regurgitation. Okay, these are the RVOTs. These are the outlet. And both gate arteries looks like coming from the outlet. Now look at this. This is important. Man. This is the aorta. It is small. It is given to neck vessel, and it is very difficult to trace aorta after first branch. And this is MPA that is big. This is a little explicit, I think. This is MPA that is big. Now look at this. Now we can see a very faint flow in the distal arch. So it suggests there is a coarctation after this first second vessel. It's a coarctation or arch interruption, and the PA ductal arch is very big. Ductal arch is very big, and there is a very trickle flow seen in the aortic arch distally. So now this is a case of a severe coarctation. We won't get a flow reversal in this case because both arteries are arising from same ventricle. As against a hypoplastic left heart syndrome, or occasionally we can see in distal gestation in coarctation. But continuous flow at the coarctation site may suggest critical coarctation. Same thing. Very, this is a big MPA and very small distal tapering aortic arch. So it suggests a TGA coarctation in a track respiratory situation. And this is the LV giving rise to MPA. This is one of the branches seen, and another branch is seen. This is the outlet chamber. Now coming to the last topic of today's presentation is aortopulmonary window. Aortopulmonary window is extremely rare thing, and to diagnose this in a fetus is still rare. I was to say fortunate enough to diagnose a couple of cases. So the diagnosis is difficult postnatally also, but in utero is very, because it's a very thin structure. It's a planar structure. The aortopulmonary window means that the partition between aorta and pulmonary artery are got two independent adventitia and muscle wall. But when they are fused and there is a continuity between lumen of these two, then it's called aortopulmonary window. There are two semilunar walls. Don't confuse this with truncus, where MPA arises from ascending aorta, or TOF with a TOF or something like that. Okay, AP window can be seen with any lesion. It can be seen with VSD, TOF, TGA. It can be seen with all sorts of lesion. So there are three types: proximal, ascending aorta, and MPA. Then in RPA, and entire length is absent. So these are the three types. Just anatomical demonstration to understand. So this patient arch interruption here, but this is the AP window. Okay, this is the pulmonary artery, this is aorta, this is the continuity window. This is the duct. This is a still image. I'm not going to show you heart in this case because it's normal. Now this is the AP window, this is the aorta, this is MP, and this is the T sign we see in VSG. Same thing, there is a hyperechoic bright images. This patient was referred to me as a dilated ascending aorta with little smallish MP and duct. So the consultant put a diagnosis whether this is a bicuspid wall aortic stenosis or something, but there was no fluid acceleration across aortic wall or AS. So this turned out to be a AP window because aorta was dilated because instead of shunting through duct, the shunting was also happening at the level of ascending aorta. So aorta got more flow and it got dilated. This is the moving image. This is the aorta, this is MPA, and this is the. Yeah. This case was published in Annals of Pediatric Cardiology. It's one of the index journal. This is a color compare. This is the window. This is the LPA and duct. Part of it, proximal duct we can see. The duct is smaller than the aortic arch. Okay, just to make my point clear. So this is the LPA. This is the window. Okay, and this is the RA. Now this is a very clear image. This is duct. LPA we have seen. This is the MPA aorta and the flow from PA to aorta. Very rare image. One may see maybe once or maybe twice in his lifetime. If you see once, it's good. So try to look for AP window in every case. You may see the incidence is like 1 in 30,000 or 1 in 50,000, like that. Okay, thank you. Hope you all like this presentation. So now we have covered close to 30 to 40% topics. We will come with more topics in subsequent presentations. Thank you.